can you tell us a little bit about the need to undertake this exercise?
So, as you know, Ricky, obviously this was a statutory, we were required to do it. So there was that bit, there wasn't much choice around that. But I think the rationale around it actually still makes sense from a trust point of view, because when having quite a big waiting list and knowing that people will be waiting for very long, there's that need to make sense of it and be sure that people who are waiting are waiting safely. There's that aspect we've spoken about, which is around the shared decision making, and that's around making sure that it's not just the clinician that's making the decision, but also involving the patient in that decision. I think that was quite important because, especially for the P5s and P6s, where patients might not be able or willing to come in, there's that added element where you want to make sure that despite them not coming in, that they stay safe, and that all possible angles have been covered and they've been informed about their choices. And so I think that bit about shared decision making was quite important as well.
Okay, so the patient say is absolutely key. As we mentioned before, finite amount of capacity to be used. So you want to make sure that every slot or test or session that you have is maximally used.
Definitely.
Yeah, okay. So for those of us who may not be quite as au fait with the terminology, could you just talk us through the P codes very quickly?
So without going into the whole detail, but essentially what the P codes do is try and split up patients into ones that need to come in pretty much straight away. So that would be your P1, A and Bs. Mm-hmm. And then you'd have your P2s who can wait for I think a month.
Yeah.
You've got your P3s who can wait for up to 3 months.
Yeah.
And then you've got your P4s who I think are 6 months. The P5s and P6s are patients who are not able to come in. So I think the key difference for me between the P5s and 6s is there might be patients who can come in, mm-hmm. but because of perhaps the social circumstances due to COVID and all, are not able to do that. And then you've got the patients who won't come in because they're just too scared or too worried. Mm-hmm. And I think that's quite important either way, because sometimes people may want to come in but can't come in. Yeah. And you don't disadvantage them because of that sort of thing.
Yeah. Okay. The national waiting list is incredibly large at the moment, and this is obviously reflected in the provider level views. What part of the waiting list is being classified first?
So for that part of the project, what we focused on was the inpatient waiting list. Mm-hmm. So any patient who had a decision to admit, those would be the patients we were looking at for this.